Great. Looks great on our side. Welcome.
Am I unmuted?
Yep, sounds good. Thanks very much.
Okay. Yes, let's just start with trying to see what is happening in South Africa and which outbreaks did we get for measles in the previous years. The ones that I've documented here is some of them, and then we'll see that the measles outbreaks in South Africa do occur, and there are some of the things that have been put in place to try and stop the measles in South Africa, but we still continue to have measles outbreaks. If you look at this table, you'll see that in 2003 to 2005, there was a measles outbreak with 676 cases, with 11 death cases in Gauteng, 8 of them which were infected with HIV. And let's look what has been done to try and prevent the spread of measles cases. During that outbreak, the interventions that were put in place was the 6 to 14 years were vaccinated in healthcare facilities, those who were admitted, and the whole country, the 9 to under 5 years were vaccinated in a supplementary measles immunization campaign. And in Eastern Cape, the cases continue being detected while after the national measles outbreak, and they intervened by doing another measles supplementary immunization in 9 months to 4 years. And then that's when the measles cases went down. And in 2009 to 2011, there was a big measles outbreak, which many of you might remember. I don't have the number of deaths, and so the intervention in this case was 6 months to 14 years, regardless of previous vaccination status in all 9 provinces. And we look at another measles outbreak that occurred after the measles, after the 2011. It was in 2017 where 3 provinces were affected. The measles outbreak started in Western Cape province and spread to Gauteng and later to KwaZulu-Natal. The last table there, I can see that I didn't put all the information, I missed it, but it was KwaZulu-Natal, where in KwaZulu-Natal, the outbreak started in August 2017 and ended in February 2018. Where, as you can see, that the measles outbreaks are still happening in our country, and if you look at the interventions, it depends on what is happening, and most of the time, the kids under 15 are the ones who are affected, and the interventions are based on them to increase the immunity in the communities. We look at how the country has been trying and doing their measles intervention regardless of the outbreak. You can see that in South Africa, measles vaccination was introduced in 1975 in children 9 months, and then later the second dose was introduced in 1995 with a second dose in 18 months, and supplementary vaccination campaigns were conducted every 4 years between 1996 and 2004, and every 3 years since 2004. This was just to increase the immunity of measles in the communities due to suboptimal protein coverage and high dropout rates between measles 1 and the second dose of measles. And you can see that the coverage was ranging from 77 to 93%, and the herd immunity for measles that is required is 95%, since measles is highly contagious disease, which shows that we are below the required vaccination coverage. Currently, the measles vaccine is given at 6 and 12 months, and the change has been when the government introduced the new measles vaccine, which is the MissBio, which was not given at 9 and 18 months. We still don't know what is the impact of that change in the expanded immunization program on immunization. So when we look at the current measles outbreak, we see that the measles outbreak started in 2022 September, week 40, and up to the information that I'm presenting is up to week 4 of 2023. We are still busy with the update on the weekly measles situation rep that we put on the NICD website. And with the last measles situation that we put on the website, 3,516, 56 serum samples were tested in NICD with a positivity rate of 14.5%. And there were 5 provinces that were affected by the measles outbreak, which were Limpopo province, Mpumalanga province, Northwest, Gauteng, and Free State province. The cases from the outbreak so far were reported as 441 measles cases, which were from week 40 to week 4 of 2023, week 40 of 2022 until week 4 of 2023. So when we look at this is the measles testing, which just show you in a figure how it looks like. And if you look in January, the specimen also started increasing, and it looks like they are decreasing. But we have realized that this is just a fluctuation. We will keep on monitoring this because the schools have opened and the festive season have passed, and then we will see what trend that we see. We were expecting to have an increase in measles samples and measles positive cases, but it looks like the measles positive cases are decreasing. This map just shows us that the measles cases have been increasing in those provinces: Limpopo province, Gauteng province, Northwest Mpumalanga, as I've mentioned. And the red dot basically shows us that the measles were reported in facilities which are closer to each other, which then made us to end up advising provinces to declare the measles outbreak, as it was meeting the case definition for the measles outbreak in most areas, which is defined as 3 measles cases in a health district within 30 days. And most of this was met even when we look at that most of them, they were epidemiologically linked. Looking at this map again, it shows that the measles is still detected in other provinces at a lower incident rate. Like you see that KwaZulu-Natal didn't report many cases, but it has some measles cases in different parts of the province. And if you look at Western Cape, if you look, majority of their cases were reported in city of Cape Town, but they will go out and investigate and let us know that they are not epidemiologically linked, giving us all the epidemiological information which include the vaccination status of the patient and also all the other requirements, and also look at the contact history and where possible, they'll even do the topical intervention of vaccinating all their contacts. This table shows us the measles cases by week, and the ones in red boxes there shows is the measles cases that were from the outbreak, measles outbreaks that were declared in those provinces. And you can see that the measles cases currently, they don't look like they are increasing, but we are monitoring to see how far we can assist the Department of Health with epidemiological information. And the other thing that might be leading to this is that the province which had measles outbreak, which has declared measles outbreak, started their measles campaign earlier with, for example, Limpopo. By that time, they started with measles campaign in under 5, and now they are upgrading to, they're increasing to the under 15, and the other provinces, they started with under 15 directly, and this might have reduced the spread of the measles outbreak. And with this, the other information that I have currently with when we have meetings with the Department of Health is that all the provinces should start their measles campaign, including the ones that don't have the measles outbreaks by the 7th of February, which is tomorrow. So looking at this epidemiological graph, it shows that the measles outbreak started in Limpopo province and started spreading to other provinces, and this was followed by Mpumalanga, where the measles cases started increasing, and later the measles outbreak was declared in Northwest province, and Gauteng province followed, and later in the Free State province. Looking at the age groups that were affected, we see that 5 to 9 were mostly affected, followed by 10 to 14 and 1 to 4 years. And this pattern has been shown mostly in all the provinces. Looking at the vaccination status of the patients, this was a concern because we realized that majority of the patients, the vaccination status was unknown, and where the vaccination status was known, there was no difference between those that had the vaccine and those which never received the vaccine. And the concern is that the ones that had the vaccine, not all of them are not fully vaccinated with 2 vaccine doses. So this is just to say that even when we don't have measles outbreak, we still have the surveillance that is going on, and this is our case definition for the measles outbreak, which happens in all healthcare facilities countrywide, regardless of the age of the patient, where the case definition is any person with fever above 38 degrees or more and generalized molecular rash with any of the following symptoms: cough, conjunctivitis, and coryza. And we expect this patient to be notified on the NMC systems, and those who are not registered on the healthcare practitioners that are not registered on the NMC system to work with their closest Department of Health to submit the NMC paper forms, which will be included, which will be captured later into the NMC system, and the blood sample collected for the measles suspected cases for them to be tested and confirmed at the National Reference Center at NICD. And the CIF should be included with the blood sample. Even if you attach the NHLS or any pathology lab, we prefer that the case investigation form be included, as it contains the signs and symptoms and the vaccination history and other complications that are related to the measles infection, including the measles outcome and severity of the disease. So these are some of the places where the information can be, some of the forms and information can be found on the NICD website. You can get the measles investigation form, the NMC form, even the expanded program on immunization guideline manual. And there's other information on the WHO website, like the measles fact sheets and the measles position paper, which talks in more details about other things that are related to the measles elimination. And on the NICD website, you can also find other information, like the frequently asked questions and for both surveillance and vaccination. These are just acknowledgement from my colleagues and other people from the province that we work with. Okay, thank you for the opportunity for sharing the information for this outbreak.
Great, thanks. That's excellent. Thanks so much. Sumari, you're welcome to start sharing in the meantime, but thank you very much, Jack. That's a nice overview, and I suppose some cautious good news in the sense that it looks like maybe the cases are coming down, although, as you say, need to stay vigilant given that schools are opening and different patterns occurring. And some really important information as well about how to send samples, what samples to send, and what the case definition is as well. So again, I'm sure those who are not familiar with it, just to go to that, some of those links that Jack shared at the end of the NICD website to have a look. All right, so it gives me pleasure to introduce Sumari Davis. She's the drug information pharmacist and general manager of Amayeza Information Services, which have done a great job in recent years. And she's going to talk to us about the measles vaccine specifically. Take it away.
Thank you, Jeremy, and thank you for this opportunity. And I've been asked to just speak to you quickly about the measles vaccines that are available in South Africa, and to highlight some of the important points that are relevant during the campaign. So the first up is the monovalent measles vaccines. In South Africa, we have two monovalent measles vaccines. The one is called MEAS-Bio, and the other one is called the measles vaccine Cipla. And the main difference is basically that the MEAS-Bio is available as a multi-dose vial, and the doses should be used within 6 hours after reconstituting the vaccine. Whatever is left after 6 hours should be discarded. The Cipla measles vaccine, on the other hand, is a single dose vial with a diluent, and you can actually mix that per patient that is walking in. So you have much less wastage with the single dose vial. Both of these are given as a 0.5 ml dose as a subcut injection. And they are both registered from 9 months of age. However, they can both be given from as early as 6 months of age. And I think the MEAS-Bio has got the provision that it, on the package insert, it states that it shouldn't be given with any other vaccines. And that's why when they swapped over to the MEAS-Bio, they moved the dose to the 6-month slot in the EPI schedule. The second lot of vaccines that we have are the combination vaccines, where we have the measles in combination with the mumps and rubella components. Both of these also administered as a 0.5 ml dose. subcutaneously, but the priorix can also be given intramuscularly. Both of these vaccines you can give from 12 months of age, and these vaccines should be used within 8 hours of reconstitution, but ideally you should reconstitute it when your patient is with you in the clinic or at your facility. Just some of the contraindications. Our patients who are immunocompromised, either due to medication use or due to disease, such as symptomatic HIV, should not receive live vaccines, including the measles-containing vaccines. For our asymptomatic HIV-positive patients, we can, however, give the measles vaccine. Our live vaccines are also not recommended during pregnancy due to a theoretical risk to the fetus. However, if it is given inadvertently, that is not a reason for termination of the pregnancy. Then also our patients who have received immunoglobulins or other blood products should preferably not receive the live vaccines for at least 3 months or longer after these products that may contain antibodies that will counteract the vaccine. Then also the MEAS bio package inserts state that vaccination should be delayed in patients with a history of convulsions until the age of 2 years. However, international data state that it's not a contraindication for vaccination, so we still recommend vaccinating our patients with a history of convulsions, but we do need to warn the parents that they can develop seizures, especially if they develop a fever as a side effect following vaccination. And these usually occur around about 5 to 14 days after administration of the vaccine. Then another point is the egg allergy, and egg allergy is not a contraindication to vaccination. In 1994, Feigang published a study where he administered MMR vaccine to 500 children who had anaphylactic reactions to egg. And none of these children developed anaphylaxis following the vaccine. And only 5 of them developed minor rashes within 2 hours following MMR vaccination. They also found that those who had allergic reactions had the reactions due to some other component of the vaccine, such as the gelatin. So therefore, we still recommend to monitor the patients following vaccination as we do with all other vaccines, just in case they are allergic to something else in the vaccine. But the egg as such has not been found to be a problem. The next component of the vaccine that may be a problem is the gelatin that is present in some vaccines, and it may be unacceptable to due to religious reasons in some of our Jewish and Muslim communities. And for these patients, we actually recommend to use the priorix because it doesn't list gelatin as an ingredient. The other 3 vaccines, all of them contains gelatin from porcine origin. So if you happen to be in those communities, remember that the priorix may be a viable option for these patients. Then I mentioned earlier about the MEAS bio that should not be given concomitantly with other vaccines. And this is stated on the package insert for MEAS bio. However, all the international data state that it can, measles vaccine can be administered on the same day as any other vaccine. And the Department of Health has actually released a circular on the 2nd of February, which is also based on information from the WHO. And they stated that during the outbreak response and national measles campaign, the MEAS bio vaccine can be co-administered with other vaccines from 9 months of age, including the HPV vaccine, because I believe there's also going to be an HPV campaign, and then also your tetanus, diphtheria, and Comirnaty vaccines. So during the campaign, it seems as though we would be able to give the measles bio on the same day as other vaccines as well. Then just looking quickly at the vaccination scheduling for our measles and MMR. And in public sector, we usually give the measles vaccine at 6 months and again at 12 months. Whereas in the private sector, we give measles vaccine at 6 months, our MMR at 12 to 15 months, and then a second dose of MMR usually at about preschool age. Now, as I understand, with the campaign dosing, the measles vaccine will be given regardless of any previous vaccination history. So even if a patient had a dose of MMR 2 weeks ago and they arrive at your facility for the campaign dose, we still administer the campaign dose. It is not going to be a safety issue. It might not be effective, but we still need to administer it in order to reach our target of vaccinating 95% of our target population. We have also heard, and maybe we'll hear a bit more from Lesley just now, but that all other vaccines should then be given at least 4 weeks after the campaign dose have been administered. And I think that's mostly just to monitor for side effects following the measles vaccination. So in the private sector, and I know a lot of our questions comes from the private sector, what we basically recommend is that we refer our patients to get the campaign dose either at school or at some public sector facility that do offer the campaign dose, because then they can be added to the statistics. However, if the parents are not comfortable in doing that and they insist on getting the vaccine at the private facility and you do not have campaign stock, what we recommend is to vaccinate those children with the measles vaccine that is due. So, for instance, if you have a child between the age of 12 months and 6 years, and they already had 1 dose of MMR, then you could offer them a second dose of MMR because it contains the measles component as well. If they already had 2 doses of MMR, then you could offer them an additional dose of the monovalent measles vaccine, so the measles bio or the simpler measles. But as I mentioned, we prefer that they go and get the campaign dose where they can be added to the statistics. Then lastly, some of the side effects that I forgot to mention that we need to have at least 4 weeks between 2 doses of an MMR vaccine. And that is mainly because if we give it sooner than 4 weeks after the previous dose, then the second dose may not be effective. So in terms of MMR, even if you have a patient who had a campaign measles dose, you need to wait at least 4 weeks after that measles dose before you give the MMR, otherwise that MMR is not going to be effective. Then finally, looking at some of the adverse effects that we can expect with the live vaccines. And we usually expect them between 5 and 14 days after vaccination. They can include mild symptoms of the diseases, such as a fever or a measles-like rash. And then with the MMR, we can also sometimes see, very rarely, swollen parotid glands following vaccination, and that's usually also around about 10 to 14 days after vaccination. It is important to note that these symptoms are not contagious if they occur following vaccination. So those children, if they do develop the rash, they do not need to be kept out of school. They can still go and attend school wherever they are. So that's from my side. If there are any questions, as Jeremy said, you can type them in the chat box. And then also just the vaccine helpline. If you have any questions on vaccines, you're welcome to contact us we are available from 9 to 5, Mondays to Fridays at that number. Thank you, Jeremy.
Thanks, Sumari. Really helpful. Super interested in the chat. If you have time, also we can ask them verbally at the end. You're welcome to stop sharing now, so we can get Lesley to start sharing when you're available, Lesley. And we welcome you, and thanks very much for taking time. I think of everyone I've ever met, Lesley's certainly the busiest. She has many hats that she wears, but including a specialist at the National Department of Health. She's been involved a lot with COVID and other outbreaks, and she's obviously very central to this Department of Health's measles campaign too. So we welcome Lesley, and thanks for.
Thanks very much, and good afternoon to everyone. I hope that you can see my presentation and hear me.
Yep, looks perfect.
Perfect. So I wasn't really sure what to present, so I've put a few slides together. I'll try and be quick, and then we can make sure that there is time to deal with any questions. I thought it was useful just to place the measles outbreak and the campaign within a global context. So I'm sure people are aware of the Global Vaccine Action Plan, and now more recently Immunization Agenda 2030, which really envisages a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. And priority 3 of the immunization agenda is coverage and equity, with a particular focus on measles, not only because it is a serious disease that is vaccine preventable, but focusing on it as a tracer, which should be identifying weaknesses within our immunization programs and guiding our programmatic planning in terms of addressing these weaknesses. As well, if we look regionally, in response to Immunization Agenda 2030, the Afro region has set a goal of eliminating measles and rubella in 80% of countries by 2030. And the elimination strategies are listed on the slide, providing 2 doses of measles vaccine in the routine immunization program, targeting 95% coverage, conducting periodic mass vaccination campaigns, monitoring the impact of vaccination activities through intensified case-based surveillance with laboratory confirmation, and ensuring standard case management of measles cases. So now, of course, we are somewhat behind. We do, and we'll talk a little bit about measles immunization coverage. And of course, in South Africa, we are one of the few countries that does not provide a rubella vaccine as part of our childhood immunization program. We do have plans to start doing that, but introduction of rubella vaccine is complicated, and we're not sure of the timelines for that introduction. And then if we look at the measles elimination targets, so the targets would be, as I've mentioned, 95% coverage of 2 doses of the measles vaccine at national level, but also across districts. Also 95% coverage in supplemental immunization activities, and then achieving surveillance performance targets of more than 80% of districts investigating 1 or more suspected cases per year, and then also having a non-measles febrile rash illness detection rate of more than, it says 2 per 1,000, 2 per 100,000 population at national level. So we do quite well in terms of our surveillance performance, but we do struggle a little bit with regards to immunization coverage. And that's really then the context in which we have to understand the measles outbreak, as well as our decisions around supplemental immunization activities. So this slide shows DHIS data for the past 5 financial years. And just to orientate you, on the left, obviously the provinces, South Africa, the national figures are at the top, and then first dose coverage and second dose coverage. So we can see that there has been a slight increase, and certainly for second dose coverage in the past financial year, we did achieve the highest coverage in the past 5 years, but it still remains below 80%. And obviously that means that a large number of children remain unprotected from measles. So it's not surprising that every 5 to 8 years we do experience outbreaks. Maybe just one disclaimer is that these figures do not include vaccinations given in the private sector. So our coverage is probably a little bit higher than shown here, but certainly remains far from optimal. So just then to talk a little bit about the campaign. So first of all, it was planned that we would have a campaign, a national campaign, and that was in response to the figures that I've just shown. So this was going to be a national campaign from the 6th to the 17th of February, so a very short period, and targeting children aged between 6 and 59 months, irrespective of whether they had received a previous dose, and linked with catch-up doses of other key child health interventions, including vitamin A and deworming. So, of course, then in October last year, the measles outbreak started. And in response to that, a number of things happened. So first of all, provinces where the outbreak was declared started vaccinating, and based on a recommendation from NAGI, but also, of course, looking at the epidemiology and the fact that the most affected age group are children 5 to 9 years of age, a decision was taken that the campaign would be extended up to children 14 years. There has, I think, been some confusion around this. The campaign targets children 6 months to under 15 or up to 15 years of age. So strictly speaking, children who have turned 15 are not included. We would hope that if these children do present for vaccination, they are vaccinated, but they will not be counted as part of the target population. Now, one thing, because we essentially trebled the target population for the campaign, there was a need to extend the campaign, and in doing that, the campaign now overlaps with the HPV, the first round of the HPV campaign, which was scheduled to run from the 17th of February to the 31st of March. So what we have done is to combine those campaigns and asked provinces, particularly provinces who are now just starting to vaccinate, that they focus on the under 5s for the first 2 weeks of the campaign, and then link efforts to vaccinate older children with HPV vaccination. So all children 6 months up to 15 should be vaccinated for the entire period, but with a particular focus on younger children in the first 2 weeks and older children in the latter 4 weeks. Of course, the fact that the 5 provinces with outbreaks have already started vaccinating means that we're not having a short, sharp campaign, which is ideal in terms of interrupting transmission. However, experience tells us that even with this longer period, we do struggle to reach 95% coverage. So whilst it's not ideal, there are more benefits for us having, in terms of coverage, in having a longer rather than a shorter campaign period. We will continue as part of the campaign to offer catch-up doses of vitamin A and mebendazole to the target groups for those interventions. So just very briefly, what is the campaign process? I'm not going to go into detail around the operational issues. Provinces are required to develop microplans. Training of vaccinators is key. Pre-campaign readiness assessment, as well as intra-campaign and post-campaign evaluation, are used as key tools to try and ensure that as far as possible we reach as many children. The operations are really looked at under 5 key topics: vaccine supply and quality, logistics, advocacy and communication, surveillance and data, and then of course right in the center, service delivery and training. This has already been mentioned because I think it is a key issue. So it is true that we, as part of routine immunization, do not recommend that MEAS-Bio vaccine is given with other vaccines. That is on the package insert, although the reason for that is not entirely clear. But as has been mentioned, during the outbreak, MEAS-Bio can be given with other vaccines, both with in children 9 months and older. So those include both routine EPI vaccines, as well as the vaccines that are given during the HPV campaign, and including Pfizer vaccines for children 12 years and older. This slide really just flags some of the issues around the service platform. I don't think I really need to go into it, but just flagging the importance and the work that we do in training people at provincial and district level, so that we are able to set up vaccination stations, both in our facilities, through outreach services, and very importantly, of course, in schools, because we know if we are going to achieve any kind of coverage in the slightly older children, then vaccinating in schools is a key strategy. One of the other key pillars that I indicated is, of course, advocacy, communication, social and community mobilization. We do achieving really good community and social mobilization is a real challenge. As national government, our responsibility is really to provide communication. We try and use mass media as far as possible, but it is very expensive to use mass media. So we really rely on partners at national level, but then of course at provincial level, to be making sure that people are aware of the campaign, and that they come forward to have their children vaccinated. Of course, starting at different times across the country has also made this more challenging. This is just an example of some of the materials that have been developed. And then finally, another key component in preparing for the campaign is to ensure that we are able to record all immunizations and report accurately with regards to coverage. We continue to aim for 95% coverage. We know that in the past that has proved challenging, but it remains extremely important that we accurately record all the vaccinations that are given. So that really brings me to the end of my presentation, and I think we have managed to have some time for questions. So back to you, Jeremy.
Great. Thanks, Lesley, and thanks to all three speakers for not only just doing an incredibly good job, but also for managing to stick so well on time. So congratulations, everyone. And as Lesley says, we've got time for questions. Some have been answered as we've gone along, but I've got a list of all the ones which people have added, which haven't, I don't think, yet been answered or benefit from another stab at them. So I'm going to start with you, maybe, Jack. There was a question. You did actually type the reply to me, but it was accidentally just came through to me about, can we notify on the NMC app rather than on the paper? Because I think this is an important question.
Yeah, Jeremy. Yes, in fact, we prefer that they are reported directly on the NMC system because it reduces the workload of capturing, and it also reduces the turnaround time of the reporting. Because when you report on the NMC system, your local Department of Health, people who are dealing with the surveillance will be able to get them immediately. And the same information will be received by NMC at NICD and other relevant stakeholders that have access to that data. So that assists a lot. And I think there are plans of, I don't know how far with the NMC group, how far they are. I think they were saying they are working on that. If you have any information to update, you can still go back and update the information. Let's say you had something missing, but you get it later, you can go there and update. And the other advantage is that if you are in a healthcare facility and you capture that directly and you use your NHLS laboratory, you have the privilege that once the samples that you send to NICD get authorized, you will also get the results directly on the track because you'll have access to that. And if it's a notified case, once it's positive, it will be notified immediately to your facility also. Over to you, gentlemen.
Great, thanks very much. I've put a link in the chat to the online portal for NMC, and also just noted that there's Android and iPhone apps available as well via the various app stores. If there's anything else you want to add on that on the chat, feel free. I hope I've got it right, but I Googled it quickly. But yeah, I mean, just to confirm, so again,
people are encouraged to register both using the app and the web-based on the same link. On the same link, you can use the phone to register, or you can use the web-based link.
Perfect. Okay. No, great. Thank you very much. Okay. So then, Sumari's a lot of questions that came through, which I think were directed from your talk. I'm just going to select a few of them. So one question was, during a measles outbreak, if a child is due for vaccination, but presents with symptoms suggestive of measles, do you still vaccinate the child, or do you postpone? And if so, for how long? So I don't know, maybe either you, Sumari, or you, Lesley.
Yeah, thank you, Jeremy. I can take that. So what we generally have with vaccines is that acute illness is a contraindication to vaccination. So if they have any symptoms, then we postpone vaccination until the child has recovered, and then we give the vaccine. So since we are running the campaign over quite a long period of time, I think it would be possible to still bring them back then a week or two later once they are better, and then administer the campaign dose.
Great, thanks very much. And then another question, which is very commonly asked, I see, is people who know that their child has been fully vaccinated, and then says, you know, they understand the campaign's rolling around saying, please, everyone get another dose. Is there any evidence of medical benefit for that, or is that just really to keep the campaign simple and obviously to enroll everyone in the campaign.
Okay, so sorry, Lesley, do you want to go?
Yeah. So look, I think it's a tricky question. So we know that measles vaccine is not 100% effective. It is an effective vaccine, but even if it has been provided optimally with no breakages in the cold chain, that it is not fully effective. I think the figure that we usually quote is 95%. So obviously the majority of children who have had 2 doses will be protected, but there are children who are not protected because of the vaccine hasn't worked, or there have been failures in the cold chain. Some of the previous outbreaks did start in private schools. Presumably children had been vaccinated in the private sector. So we know that there are breakages in the cold chain in both the public and the private sector. So for that reason, we do recommend that all children are vaccinated during the campaign. It is a safe vaccine. And there's very small chance of any adverse events. So certainly from our perspective, we recommend that all children are vaccinated, although obviously the benefit for an individual is relatively small. Maybe I can just answer, from our perspective, we do recognize that children with acute illness, it may not be appropriate to vaccinate them. But our adage is that in general, if children are well enough to go home, they are well enough to be vaccinated. We would not recommend vaccinating a child with a high fever, more than 38.5, but mild illness associated with a mild fever, we do not consider to be a contraindication to vaccination. Particularly in settings where it may be difficult for the family to come back, or one is vaccinating as part of outreach services. So the services will not be available if one delays. Let me stop there. Thanks.
That's really helpful. Thank you. So another question that's come up in probably for you, Lesley, is about independent schools, saying that they're not included in the HPV. Sorry, I beg your pardon. Saying they weren't included in the HPV vaccination. Sorry, but will these schools be included in the measles campaign? So do you have are you going to go to the private schools as well, or is that up to them?
So that will be up to the provinces and the schools themselves. Unfortunately, it is true that we only vaccinate, provide HPV vaccination in public sector schools. Again, because of the staggered start and the somewhat late addition of the school-going age group to the campaign, at a national level, we don't have sight of every school that is going to be visited or not visited. So I think the advice that we would give is if parents are in private schools and to some extent in public schools, is to check with their school whether their vaccination will happen in the school, and if not, to access vaccination elsewhere. Obviously, it is much easier if vaccination teams are coming to schools. When we vaccinate in schools, we do require parental consent. So children will not be vaccinated in schools without parental consent. Thanks.
Thanks. And then just one more to you, Lesley, if you don't mind, before I go back to Sumari. The question is from Sumari, saying, can Measles Bio therefore be administered with Rota-Tec and OPV at 6 months as well?
So the answer to that question is no, because the the circular does talk about from 9 months it can be administered with other vaccines. So in the public sector, we don't give any vaccines routinely between 6 and 9 months, but it does mean that, for example, a 7 or 8 month old child who will not be able to receive catch-up doses of some of the vaccines that should have been given earlier at the same time as measles. But from 9 months, any routine or catch-up doses can be given at the same time as the measles vaccine.
Okay, no, thank you. That's very clear. Sumari, just a couple of questions for you. One is just about a very short one about Priorix Tetra being out of stock, and if you know whether it's in stock now. But then I wanted to just follow it up with also a separate question saying this was a case that was given in the chat about a 10-month-old who received the 6-month dose already. Which measles vaccine must they get at this point then at 10 months? Thanks.
Okay, so let me just find those questions quickly. So the first one, just say again, please, Jeremy.
Sorry. It's the Priorix Tetra has been out of stock. Just question, know if it's back in stock at the moment?
Okay, as far as I know, it's not back in stock. They are awaiting new stock, but with the measles outbreak, there has been a huge increase in ordering, and I think they used like 3. My colleague just told me Priorix Tetra has been discontinued. So the Priorix is out of stock, and the Priorix have been sold out very quickly with the measles outbreak at the moment. So the Tetra is not available anymore. It's been discontinued, but the Priorix is also out of stock. You can, however, try order Omzyta, which is also an MMR vaccine.
Thanks.
Okay, and then
yeah, sorry. The second question was about a 10-month-old who had received the 6-month dose of measles vaccine. So what must they now get?
Yeah. So they can get another monovalent measles vaccine. The reason being because of the maternal antibodies that may be circulating in the baby. The vaccines are not as effective if given before 12 months of age. So at 10 months, we would rather give another dose of the monovalent measles vaccine and then continue with your MMR vaccines from 12 months and older. However, having said that, the MMR vaccine can be given from 6 months of age, but you won't count it as a valid dose. So if you give MMR at 10 months, then you would still need to repeat it at about 10 to 15 months of age, and then another dose to be given at 6 years of age.
Thanks. That's very helpful. We just passed 4, so I just need it was one last question basically before we move on to the second half completely. But just perhaps Lesley, to you, one of the questions that came through is about COVID pandemic, and one of the reasons potentially for a drop-off in routine vaccinations that were given, and just wondering whether you suspect you may see any other outbreaks of childhood infections like pertussis or diphtheria or anything else we've been vaccinating for. I know measles is sometimes the canary down the coal mine in some ways.
So thanks. So of course we are extremely worried that some of the vaccine hesitancy and the anti-vaccination sentiment that has been very prevalent during the COVID vaccine rollout will spill over into childhood vaccinations. We in the past have seen very little vaccine hesitancy, and the main reason in our understanding for less than optimal uptake is really around difficulties with access and to some extent supply, rather than hesitancy on the part of caregivers. So we are nervous about that, and we're watching very carefully. As I indicated, in the last financial year, we had higher vaccine coverage than than in the previous 4 years. So there's no sign of it currently, but we're watching very carefully. We are currently or have been experiencing pertussis outbreak. That's probably more as a result of the vaccine that we're currently using. And to prevent that, we are going to have to start using vaccinating pregnant women against pertussis. So we're watching very carefully. No signs yet, but obviously there's a lot of work to do to make sure that we do maintain and improve our vaccination coverage. Thanks.
Thanks, Lesley. And thanks to all three speakers, Jack Manamela from NICD Epidemiology, Sumari Davis from Amayeza, and Lesley Bamford from National Department of Health. We're going to end our first half there, so thanks very much to our three speakers.